Thank you, Mrs. Chairman. And I would like to thank the organizer for their kind invitation. I'm delighted to be here. I was in Egypt a long time ago, almost 30 years, so this is kind of my comeback to Cairo, beautiful Cairo. Very good. So in the next 30 minutes, we're going to talk about anemia and chronic kidney disease. I know not all of you have been involved in kidney transplant or kidney donation, but I assume all of you are managing chronic kidney disease and anemia. And so I'm going to start with, or this is my disclosure slide, really nothing relevant to this talk. And before I kind of show the outline, I'm going to jump in the case. I'm hoping this will be also as interactive as the prior session, and kind of sharing some of your idea or practices as well. So I'll start with this case of a 58-year-old woman who was referred by her primary care physician to the nephrology clinic because of anemia in the setting of chronic kidney disease. And she has so it's typical case that we all have seen, has long-standing history of GERD on omeprazole, hypertension on lisinopril and hydrochlorothiazide, and history of ankylosing spondylitis, for which she has been taking non-steroidal anti-inflammatory medication on an intermittent basis, typically 4 or 5 days a week, every 4 to 6 weeks. And 5 years ago, she was diagnosed with type 2 diabetes. At that time, her hemoglobin A1C was 9%, but with medication, she got it under good control with diet and metformin. So she doesn't have any allergy. She had 2 pregnancy, healthy pregnancy, and her surgical history included a cholecystectomy. This is her vitals, which is a little bit on the overweight side. Otherwise, blood pressure is pretty good. Her exam otherwise is unremarkable. And this is her laboratory. So her hemoglobin is 10.9, and she has a normal MCV, lower on the lower side, but still in a normal range for our laboratory. And you can see her electrolyte, and her creatinine is 1.1. I apologize, I didn't put the international unit we use in the US, milligram per deciliter, but her estimated GFR is 55. And then her urine analysis shows some albuminuria, so that will be considered grade 2, above 30 milligram per gram. And then I'm adding here that 3 years ago, her creatinine was 0.9 with an estimated GFR of 69. And her kidney ultrasound was consistent with some CKD, mild echogenicity, otherwise nothing remarkable. So the question for you here is based on what I presented in the case so far. What do you think the cause of the anemia is most likely due? So one, iron deficiency from occult GI bleeds. And if you think this is the answer, just raise your hand, and I'm going through those different options here. Anyone thinks it's first option? Possibly, okay. I have a couple hands up. Vitamin B12 deficiency. Okay. Very good. Okay. Erythropoietin deficiency from CKD. No one likes this option. Okay. How about chronic inflammation secondary to her? Okay, I have a couple hands up there. Okay. And then unable to determine. Okay, couple hands up as well. Okay, so let's first, so I'm hoping that in the next, 25 minutes here left, talk about a little bit prevalence of anemia in chronic kidney disease, the pathophysiology of anemia, how to evaluate anemia, and I have to mention that the KDIGO guidelines are just coming up, the updated one. They are not yet officially published. They are under it's open now for public comments before they kind of finally publish them. But I can mention a few points from these guidelines. Talk about the treatment option for anemia and the target goal, and then depending on time, we'll talk about a little bit transfusions. Starting just for making sure we're on the same page here, as far as the anemia definition according to the World Health Organization is defined as hemoglobin less than 13 for men and non-menstruating women, or hemoglobin less than 12 in menstruating women. And obviously we know that for this audience, we all know that anemia worsens as CKD progresses, but it's really everybody's kind of different, and it's not homogeneous, and that's why we have to monitor regularly. So this is a kind of older study from population base in the United States, and looking here at on the x-axis GFR, estimated GFR, and then on the y-axis a percentage of a patient who have anemia, and there's two lines there. The first one on the top is a hemoglobin less than 13, and the one below on the solid line is a hemoglobin less than 11. And you can see that as for this patient, for example, her GFR is just below 60%. Or 60 ml per minute. And so you expect hemoglobin to be less than 13, somewhere in the 20% range. So that's kind of not unusual in this situation. Now, her hemoglobin was little less than 11, and that's a little bit more unusual because, according to that study, is only 2% of women will have, or patient with CKD will have hemoglobin less than 11 at this GFR. So you have to think about, and this is now, there's a little bit, if you divide actually between diabetes and non-diabetic, so diabetic will be more likely to have anemia, and in this case, up to 16% will be anemic. So certainly not unusual, but kind of raises some flag, right? So we cannot just assume that the anemia is from chronic kidney disease because of erythropoietin deficiency. You have to think about more like a diagnosis of exclusion. Is there something else that is driving the anemia? So that's kind of the wanted to highlight here. So that's why most likely here what I kind of would say, we cannot really determine at this point based on what I presented what's the cause of the anemia yet. So we have to do more study, but a little bit a word on the pathophysiology of anemia. As kind of the last decade there's been more discovery, especially with the hepcidin. But we know that in chronic kidney disease you have less production of erythropoietin, but there's other contributor as well, the uremia by itself, and it's not uncommon for these patients, our patients, to have blood loss or iron deficiency because of diet with a lower protein. But inflammation is a big component, right? And inflammation can cause anemia in various different ways, by decreasing erythropoietin production, by decreasing the lifespan of the red blood cell. But that's kind of the excess of hepcidin, right? And hepcidin is a key role, and probably the most common reason or the primary reason for anemia of inflammatory disease, also outside the chronic kidney disease, is a hepcidin, excess hepcidin. So what is hepcidin? So hepcidin is produced by the liver, and hepcidin interacts, so it's increased in the setting of inflammation, and hepcidin interact with the iron channel ferroportin, which is found on various places, including the duodenum. That's kind of allow the iron to be reabsorbed through the gut. And then also it allows the movement of iron from outside the storage areas, which is the macrophage or the reticuloendothelial system. So if you don't have ferroportin, you cannot mobilize the iron to move from the blood to the bone marrow to be part of the erythropoiesis. So that's why if you have high inflammation, high hepcidin, then you're not going to be able to, so you're going to develop anemia. So that's kind of a key pathophysiological part. So I'm going to skip over there and just a little bit about the symptom of anemia. I mean, we all know that it could be very, very mild to kind of more severe, but as anemia gets typically very progressive in those patients, many patients are completely asymptomatic, right? But some patients will experience fatigue or shortness of breath. And I mentioned this because I'm kind of going to talk about, how often patients are aware of their anemia. And so how do you investigate anemia? And this is kind of based on the KDIGO, the updated KDIGO guidelines. Kind of the first step, the basic is, obviously you have to do a CBC and the absolute reticulocyte count, but also check the iron. That's kind of first thing you want to do, ferritin and the transferrin saturation. Now, if all the iron store are normal, then you can do the more advanced screening and then kind of do everything else that I'm listed here as potential contributor for the anemia, obviously depending on how patients are presenting and their symptoms. So, and then one word about the iron deficiency. There's two two major things here. You can have absolute iron deficiency or a functional iron deficiency, right? The main difference is in both cases, the transferrin saturation is going to be low, but the difference will be in the ferritin. So the absolute the iron deficiency, your ferritin is going to be low as well, so that because your store are low. While in the functional iron deficiency, that's kind of associated with inflammation, your store are fine. You have enough iron, but the iron just cannot be mobilized. And so if you're looking at in a diabetic population, up to 10% of patients who have ASA resistance is because of the inflammation and the high hepcidin level. So let's kind of come back to our case here. So we did a complete evaluation of the anemia, and everything was unremarkable. And I kind of, in particular, the iron store, B12, folate, retic count were or normal. So the nephrologist at that time thought that this is, tell the patient that you have stage 3A, chronic kidney disease, multifactorial from hypertension, diabetes, chronic NSAID use. He recommended to stop the NSAIDs. And he added SGLT2 inhibitor.
I have a question
Yes.
before you go.
Yeah.
Thank you. So would you do all that workup if her GFR was lower and she has mild anemia?
Yeah, so it's all depend, if you have suspicion for other reasons, because the anemia of CKD should be a diagnosis of exclusion. So you really have to kind of think about, is there something else? I will typically check a B12 and folate because it's kind of easy way to screen. And I do check thyroid hormones as well because it's kind of not uncommon to have hypothyroidism. I don't necessarily do everything else. I don't necessarily need to do like a GI workup, like a stool check, unless I have suspicion that there is a GI loss, especially if the iron stores are normal. I wouldn't necessarily do the GI workup.
Would you check for it and B12 if MCV was not, or only if the MCV is higher?
Yeah, I mean, it's normally you would check if the MCV is typically if you have vitamin B12, it's a good point that deficiency, your MCV is going to be high. But it's not always a situation. Sometimes you may have some iron deficiency as well associated. So the MCV, I typically would do it even if the MCV is not high. You have a comment? It's not as common. I mean, I don't have kind of exact number, and I think what I looked at was less than 20% of the situation where you may have deficiency was still a normal MCV. Yeah.
And she was on metformin, correct? Like you have already mentioned correctly. So with the metformin, these people should also be taking some supplements, correct? For anemia B12. So that increases the risk because she was also on metformin.
Yeah, excellent. Yeah, very good. Excellent point. Okay. Other questions or comments? Okay. Oh, I thought that was a comment. Okay, I'm going to. So the next question here is how often would you screen for anemia in the setting of chronic kidney disease? So anyone says every month? Okay. Very good, right? So yeah, I mean, this is kind of more kind of to bring this discussion, right? So the frequency really depend on the stage of chronic kidney disease, right? So and so typically this is kind of what the suggestion of the KDIGO guideline. No, most of what's in the guidelines are really not high level evidence and not high grade. That's kind of true for most nephrology, most of the nephrology field here. But typically, in the absence of anemia, right, so you check at least annually if you have stage 3 CKD, twice a year if you are at stage 4, and then every 3 months at stage 5. But if you're already anemic, then typically you will kind of check every 3 months. Unless you're already on erythropoietin stimulating agent, you may want to check more frequently. Obviously, you have to individualize this based on the patient trend. And everyone is different. Now, I wanted to kind of highlight here that chronic anemia of CKD is very underdiagnosed and undertreated. There are several studies here, so I can just kind of highlight a few of them. But really, for example, the first study here I'm showing was 45,000 patients. There's 26% of patients had developed anemia, but only 15% were diagnosed with anemia, and only almost 20% received treatment. And so these studies have been replicated. So we're as a community overall, we're not doing as good. Now, it wasn't clear here, these patients were not necessarily seen in a nephrology clinic on a constant basis. Many are followed by primary care physicians. But this is kind of another study where they kind of look at, I think this was based in Canada, but they look at, the importance of shared decision-making with patient and education. And so in that study, or the survey, they had almost a third of patients were unaware of the relationship between anemia and chronic kidney disease. Half were not aware of their hemoglobin level, and half of them did not know what treatment are available for their anemia. So that kind of highlight the importance of us really kind of discussing with patient, educating these patients. Part of that role is our role, but also our nurses and our support in the clinic. Education takes a lot of time, and many of us may have limited time in the clinic. So I don't know how it is in Egypt. I know in the United States. Time is very precious, and so we kind of utilize our nurses and our educator to do a lot of the education for our patient. Obviously, we do discuss this with the patient, but patients have so much on their mind, and chronic kidney disease is such a complicated condition with a lot of implication, and if you're doing a 30-minute appointment or more or a little bit less, that's not enough, and patient needs to hear this all the time. So this kind of so going back to the case. So this patient 3 months later actually kind of comes back because she had developed GI bleed. This was attributed to peptic ulcer disease from the NSAID use. Her hemoglobin dropped from 10.9 to 9.2. And the bleeding is eventually resolved spontaneously, and she was on PPI. She had stopped it in the meantime, so we can so the PPI was resumed. And then 2 weeks later, her hemoglobin started slightly up from 9.2 to 9.6. And at that time, iron panel was checked after the GI bleed, and so her ferritin was 85, and the TSAT is 25%. So based on these numbers, what would you do next? If this is a patient in your practice, would you recheck hemoglobin? Don't do anything and just recheck hemoglobin in 1 month? Anyone would like to monitor and recheck in 1 month and not do anything else? Okay, doesn't seem that everybody wants to do something. How about starting a erythropoietin stimulating agent? Anyone would start? Okay, a couple hands there. How about iron supplementation? And here you can do it orally. I put 2 options, okay? And there's not necessarily one correct answer here. It's just more for us to discuss. Orally, anyone wants to give iron orally? Okay, there's a couple more hands here. How about intravenously? As well, okay. How about anyone want to transfuse her? Give her a unit of red blood cell? Okay, everybody is shaking their head no. Okay, how about starting a HIF inhibitor? Okay, so again, and no one is excited about that option. Very good. Okay, yes. Yeah, so that's a good question. I'm not sure. Actually, you may answer this better than me because you're the expert in these agents. I don't know how frequent you can get anemia and what's kind of the pathophysiology.
Theoretically, they increase the erythropoietin release from the tubular cells, and they may improve anemia. And maybe one of the causes or one of the factors that contributed to this patient's anemia, something that we don't consider, that actually RAS inhibitors may induce some degree of mild anemia, and they can be a cause of this anemia.
Yeah, no, that's excellent point, and yeah, obviously when you have erythrocytosis, sometimes we kind of start them on a RAS blockade to kind of lower that. Now, would you think that in her situation, I mean, she's been on the ACE inhibitor for a long time, and her hemoglobin had kind of probably lower than what we would expect.
The benefits, I think, outweigh the risk of the anemia. So although they are associated with some degree of anemia of maybe 1 gram less than the usual, but I think their benefit in as regards cardiovascular mortality, as regards CKD progression, outweigh that risk.
Excellent. Yeah, right. So we certainly want to delay the CKD progression. Yeah, excellent. Very good. Any other comment or question? So how, and I don't know about the practice in Egypt. Is it easy to provide IV iron? I don't know if patient likes it or not. It's kind of cumbersome, or it's not. I mean, do you start with oral and see what happens, and then switch to IV if anyone wants to comment on that? Okay. So when you say like, is this because I dislike the oral iron, or? Okay, yeah.
It's more effective, and we don't like the constipation that is present in iron.
Okay, very good. Anybody? Yeah. So this is really all excellent point. I mean, I think the guidelines would say that you can use either, and I think I have it in the next couple slides there. But first, in this case, she's indeed iron deficiency, and this is kind of the definition of iron deficiency for patient not on dialysis: either a ferritin of less than 100 with a T-sat of less than 40%, or a ferritin between 100 and 300 and a T-sat of less than 25%. So this patient qualifies for that. Now the guidelines suggest is you can do either IV iron or a trial of oral iron for 1 to 3 months, and based on response, you would decide and switch to IV iron if there's no good response. But really, it's kind of about individualizing it, right? So some patients prefer, okay, I don't want the IV because you have to give it over a couple sessions. Maybe oral is easier. Some people don't like the oral. It doesn't matter, but obviously the more effective is to give it intravenously. Yeah, in our practice, I mean, we do either way. It's kind of shared decision making with the patients and see what if they can get just by the oral or just be done with the IV. And I'm going to move on. So now we have different formulation of iron. There's some advantage and disadvantage for each. Some you can just give it in one dose. Some you have multiple dosing. Some are more expensive. Some are less expensive. I don't know which one is more commonly used in Egypt here. But for our dialysis patient, we typically use iron sucrose because they are already on dialysis. And so it's kind of easier to do it that way. But in our CKD clinic, we often use the ferrimoxitol or the ferric carboxymaltose. A little bit less first option because costs tend to be high and depending on patient insurance. So that's kind of how we typically decide. So that's kind of and so going back here to our case, she completed a course of IV iron. Her hemoglobin goes up from 9.6 to 10.5, and her iron store are really much better. So the ferritin goes up to 255 from 85. Her T-sat is up to 38% from 25%. And so the question here: would you start her on erythropoietin stimulating agent? No. Okay. And so the kidney function is at this point haven't changed. So her GFR is still in the 50s.
At her GFR.
Yeah, very good. Okay, yeah. But typically with a hemoglobin of 10.5, would you start erythropoietin stimulating agent? Anyone? We heard no. Anybody would say yes? No. Okay. Very good. Yeah. So I mean, you're very familiar. I'm not going to go there, but for those I mean who were nephrologists before '89, transfusion was pretty common. People were very anemic, and the introduction of the erythropoietin really changed the practice completely, and it's kind of really avoided quite a bit of transfusion. Now, initially, we were targeting a normal hemoglobin because we thought, okay, normal is good, right? So we wanted to get hemoglobin to normal. But then studies start coming up. First one actually was a normal hematocrit study in 1998 showing that there's more increased event like death and myocardial infarction and thrombosis of the vascular axis. So the DOKI guideline at that time changed the target to 11 to 12. And then since there have been a lot of different studies, I'm not going to go through the details, but the CHOR, CREATE, and TREAT that showed consistently that you shouldn't target a higher hemoglobin level because of increased risk of stroke in particular, but also some cancer as well. So the FDA at that time kind of issued a warning, and then I'm putting here that you should not use ESA once your hemoglobin is above 11 because of the cardiovascular event risk, and you shouldn't make frequent adjustment, limit this to every 4 weeks, and use the lowest dose possible to avoid the need for transfusion. Now the KD DIGO guideline from 2012, they kind of also added the change in hemoglobin, how fast the hemoglobin is dropping. So you don't necessarily need until your hemoglobin is dropped below 10. Kind of you have to account for how quickly the hemoglobin is dropping. Also depending on patient symptoms. So some patients really feel very tired and run down when their hemoglobin is less than 11. So the guidelines at that time say you really need to individualize it according to each patient. And so the new guidelines here say, the target should be hemoglobin of less than 11.5. So that's kind of a recommendation class 1, but the level of evidence is really not very high as far as maintenance ESA. Few words on the HIF pH inhibitor, or this is hypoxemia inducible factor. Propyl hydroxylase inhibitors, but that's kind of a major, the way erythropoiesis happens is because of the hypoxemia inducible factors. And so there have been development of agents to inhibit this. So the propyl hydroxylase, and then this is, I think I have it in the next slide. Or maybe I missed that slide. But anyway, so the HIF factor, there's 2 units, the alpha unit and the beta unit. So the alpha unit is get with a propyl hydroxylase get degraded in a normal situation. But if you have hypoxemia, then this kind of gets transcribed inside the nucleus and then stimulate the stimulation of the factor that produce erythropoietin and stimulate erythropoiesis. So this factor or this agent, there are a couple of one have been investigated, and I believe in Egypt the roxadustat is the one available, but I don't know if this kind of have changed at least from my understanding. But there's several one have been on the market, and for the sake of time, I'm going to move in here. But there's so each agent, I mean, some agents are approved in some countries, some not. There's different dosing. I don't want to go into all those details there, but they're appealing, right? Because they're oral agents, so there's no injection needed for chronic kidney disease patient. If you're not on dialysis, that's a very appealing option. This is the cartoon I was going to show about the HIF subunit. And there's several clinical trials that have been published. This is with roxadustat, for example, was a phase 2 trial showing that hemoglobin is improved compared to placebo, and the hepcidin level is also reduced. So there's kind of really decrease the hepcidin level, which is kind of one of the major way of in the pathophysiology of anemia. And then this is comparing to apoetin alpha, showing like non-inferiority compared to apoetin alpha. But unlike the ESA, the hepcidin level with this agent is reduced. And this is the phase 3 trial also in almost 800 patients was against placebo, but show hemoglobin increased by 1.75 gram compared only increased by 0.4 in the placebo arm. And there's 2/3 or 63% decrease in the need for transfusion compared to the placebo with a very similar side effect. Now there's concern also like the ESA about cardiovascular event. And recently there was a systemic review and meta-analysis showing actually no evidence of a difference in the long-term cardiovascular safety profile. Very quickly here about transfusion. The main message here is avoid as much as possible transfusion, especially if someone is eligible for kidney transplantation potentially down the line. There is a nice algorithm. This is from actually the 2012 KDIGO guidelines. Oh, I don't know what happened here. Someone is moving the... but basically, if you have acute bleeding or chronic situation where you have ESA resistance because of bone marrow failure or ESA resistance, obviously you have to do transfusion. But otherwise, thinking about the patient, is this patient a potential transplant candidate? And if yes, if there are higher risk of alloimmunization, you want to avoid transfusion as much as possible. Obviously, if you have to do it, it's important to discuss with the patient about the risk. So finishing up here with the last couple slides. So this is 6 months later. This patient had some mild fatigue, but was otherwise doing well. Blood pressure has been well controlled. Diabetes more difficult to control. And then her labs here show hemoglobin has dropped to 9.2. Creatinine has increased further, and GFR is 44, down from 55 3 months earlier. The albumin-creatinine ratio has increased more, and the 24-hour urine protein we did at that time was 1,300 milligram. So quite increase. And so the last question I have for you here, so what would you do next? Do you want to intensify her diabetes treatment because her hemoglobin A1C has gone up, or you double dose of the ACE inhibitor to reduce the proteinuria, start ESA, continue therapy and have her come back in 3 months, or something else? Okay, reassess iron status. Okay. Anybody wants to do anything else? Very good, yeah, excellent.
But you could potentially use the medication as excellent point, right, which would control blood glucose as well as proteinuria. And in fact, these SGLT inhibitors act through the hypoxia-inducible factor. So as you said, they may help with anemia as well. So
okay.
Very good option.
Can you give me one more minute to show my last slide here and see what happened with the patient? Oh, I'm sorry. Oh, okay. So basically, because I mentioned the proteinuria has increased quite a bit. Sorry, I didn't see that. Yeah, so the proteinuria has increased quite a bit, and GFR was declining. So we did the SPEP and the UPAP, and this patient actually found to have monoclonal protein, and we can refer her to hematology. They did a bone marrow biopsy, and they confirmed that she had underlying myeloma. Very good. And so these are my summary points. So screening for anemia should be done periodically at interval based on CKD stage. Anemia does affect quality of life, and so most patients are underdiagnosed and unaware that CKD causes anemia. Epoetin and hepcidin are key players in the anemia of CKD, and you always want to check iron panel before you start ESA or HIF pH inhibitors. And with that, thank you for your attention. I apologize for going over time here.